Thank you for having me here today. Again, my name is Liz Upton. I'm a statistician at Williams College. This is collaborative work with a group at CBAR at the Harvard School of Public Health. One small note, as a statistician, I'm not as well versed in some of the medical terminology I've been hearing at this conference. So apologies if I can't answer all of your questions. That being said, I'm a big proponent for collaboration, a fan of the getting to that unicorn on that Venn diagram. So I'm happy to take all of your feedback, and I'm looking forward to hearing your thoughts on the analysis. All right, so just a brief outline of my talk today. I'll mention why we're choosing to look at long COVID with a network approach, describe the data and the goals for our analysis, briefly outline the methodologies that we've employed, and then jump right into the conclusions of the analysis and the next steps. So why a network approach? Well, Dr. Jamie Rylance from the World Health Organization in February of 2024 had this to say about long COVID. The symptoms are very variable. Patients may have difficulty recognizing that they have it, and healthcare workers, to be honest, can also struggle to identify it. And I think that's been a little bit of a theme here at this conference as well. The symptoms are variable. They can be quite complex. And networks as a data structure allow us to represent complex systems and learn from those symptoms more simply. So what is a network? Well, the term network refers to a collection of elements and their relationships. We call those elements vertices or nodes, and then the connections we denote with edges between those nodes. So in the application today, the nodes of our network will be long COVID symptoms, and then the edges represent conditional dependencies. So that's a dependency between two symptoms that also account for all of the other symptoms and connections in the network. And I've provided you with a visualization of a network below. I'm stating that this is an informative data structure and that we can learn a lot just from the picture. All right, and then with follow-up statistical analyses, we can look at how the nodes tend to cluster. We can rank the nodes based on their centrality or their importance in some sense in the network. So there's a lot to learn. So the data that I'll be presenting today comes from the Active-2 platform trial, and this was designed to evaluate the safety and efficacy of investigational agents for the treatment of non-hospitalized adults with mild to moderate COVID-19. So included in this data are self-reported measures of 27 targeted symptoms, and those were collected at weeks 12, 24, 36, 48, and 72 post the acute phase of COVID. And we'll be looking at data from 2,824 participants. So the objectives are our analysis. We wanted to use the symptom diaries from the participants to infer a symptom network, and then identify symptom clusters, that is, groups of symptoms or conditions that share dependencies and are more densely connected within the network. We want to identify core symptoms in the network, that is, somehow rank the symptoms based on some measure of importance, determine if the network changed over the course of the study, and then also determine if the network changes if we first stratify the participants based on a question in the diary. So here's what the symptom diary looked like. This is what the participants filled out. Hopefully the text is large enough and you can take a look at question 1. This is how we stratified the participants. It reads, please choose the response below that best describes the overall severity of your COVID-19 symptoms over the past 4 weeks. So this question allowed us to stratify the participants based on those who felt as though their symptoms, they could attribute them to COVID-19 or not. Because if you look at question 4, which is just asking the participants to indicate the overall severity of their symptoms, there's nothing there about COVID-19 specifically. All right, so how do we go from those symptom diaries to a network? So what we do is we take all of the participant information and we store it in this matrix X. It's a number of participants by number of symptoms matrix and dimension, where the ijth entry of that matrix will be a 1 if participant I reports symptom J in their diary and a 0 otherwise. And then we're going to use this matrix to perform a series of penalized logistic regressions. That is, we hold one of the columns as the response variable and all of the other columns as the explanatory variable and collect the betas, collect the coefficients. And it's those coefficients that represent the conditional dependencies between the response variable and the explanatory variables. And we iterate through the entire matrix, holding each column as the response variable, in the regressions. And the key here is that we are performing a penalized regression, as was introduced in the previous talk. What this does, it's going to shrink a bunch of those beta coefficients to 0. All right, so in our case, that would indicate the lack of an edge in our network. And the non-zero coefficients indicate a conditional dependency, and it will appear as the edge in the network between two symptoms. So after we infer the network, there's a number of different follow-up analyses that we can perform. I mentioned the clustering. We'll use the walk trap algorithm, and this will allow us to identify groups of symptoms that are densely connected. We also want to assess the variability of this entire process, right? We're inferring the network. So how much kind of confidence can we have in that process? So we employ a bootstrapping analysis where we're basically going to regenerate the network 1,000 different times. And this allows us to create confidence intervals that describes the edge weights or the strength of those conditional dependencies that we'll see in the network. We can also use those bootstrapping results to determine the strength or the consistency of the clusters that we find through the clustering algorithm. And then when we're comparing two independent networks, we can do things like permutation tests to see if they are indeed significantly different in one manner or another. Okay, so now getting into the data, the results. Here are the symptom counts over time for the participants. The different colors in this bar graph correspond to the different diary weeks. And you see in the legend there the count of the participants that submitted their diary at each week as well. So for example, fatigue was the most commonly reported symptom. Another thing I kind of take away from this visualization is we don't see a particular pattern over time. That is, within each of the symptoms, the bars are relatively the same height across the symptom, and there's not a ton of variability there. And here are the remaining symptoms that we looked at. Because of this, our first stab at inferring the network, we actually collapsed time. So in this way, in that design matrix X I showed you earlier, there'd be a 1 if a participant ever reported a particular symptom and 0 otherwise. And, drum roll, here is our inferred network. So the colors here represent the results of that clustering algorithm that I was talking about before. The size of the node represents the frequency that symptom was reported. And then the thickness of the edge corresponds to the strength of the conditional dependencies between those symptoms. I can also speak offline as well about the algorithms we use to plot the network and position the nodes if that's something people are interested in. So kind of getting at the describing the variability that's inherent in this network, these are the results of the confidence intervals for the 25 largest edge weights that you see. So we see that the largest or the strongest dependency is between smell disorder and taste disorder. All right. This is shown on this network because if you look at the bottom and those two dark green nodes, you see the thickest edge between taste disorder and smell disorder. One thing we can take away from these confidence intervals is that for some of the relationships, they are indeed statistically stronger. They're significantly stronger than the other ones. So there's information here in the thickness of these edges that you're seeing. I apologize, this isn't the best visualization, but I was trying to get at how we can rank the nodes as far as different metrics of centrality. And I looked at 4 different measures of centrality. They all kind of capture different things. Here you see the symptoms we looked at on the y-axis. And then for those symptoms with dots farther to the right, closer to 1, those would be the highest ranking. So for example, we see fatigue is very central to the network, which kind of makes sense. It jives with their intuition, given it was so prevalent. We also see difficulty with concentrating and thinking, concentration and thinking. That one I find kind of interesting. If you notice, it's one of those pink nodes. I don't have a pointer, I apologize. But really, I think this is important to the network structure because it seems to be acting kind of like as a bridge. That is, if you're experiencing that symptom, you have kind of a connection between those other nodes in pink, the symptoms in light green, and then even down to the symptoms in dark green, taste and smell. This is a schematic that shows us how confident we can be in those cluster assignments. So in those 1,000 bootstrap networks, it tells us how often 2 symptoms were categorized into the same cluster. So the darker the square, the more often 2 symptoms were categorized to be in the same cluster. So for example, we see at the bottom there, memory loss, difficulty with concentration and thinking, difficulty reasoning and solving problems were almost always in the same cluster. And then hair loss sometimes was paired with those other 3 symptoms. My big takeaway from this is that there does seem to be a consistency in the clusters, and they are pretty well defined, given you see these kind of darker squares along the diagonal. Oops, wrong way. Okay, speed it up a little bit here. I'm running out of time. This is the comparing the networks over time. I mentioned we had collapsed the symptom diaries before. This is what it looks like if we don't do that and we create networks based on the symptom diary for each week. You'll notice there's not too much variability, not too much difference here. I highlighted the new edges or the edges that appear in these networks and not the one we looked at previously in purple. Now, getting to that question 1, this is when we stratified the participant pool based on those attributing their symptoms to long COVID versus those who are not. In orange, you will see those attributing their symptoms to long COVID. They are reporting a very much larger frequency of all of the symptoms in the symptom diaries, which you see in the orange bars there compared to the green bars. That being said, the networks aren't all that different. We do see some differences. For example, this cluster in the dark green down below, taste disorder, smell disorder, you see in network B, these are the participants attributing their symptoms to long COVID. They are connected, those symptoms are connected to the main component. Whereas for participants in Group A, those symptoms were not connected. We also see things that stick out to me. Skin rash is much more connected to the network, as with chills. And you can study this. There are a few other things that stand out. We also see some significant differences in the density of the graph of the network. In picture B, we ran permutation tests to discover this. This is what that clustering analysis looks like for the bootstrapped networks in both cases, and I'd argue that you can definitely see the pattern of the clustering more strongly for the network built based on the participant information, who again are attributing their symptoms to long COVID. So it seems to form tighter communities of symptoms. These are the results of the permutation tests that I was talking about. I won't go through this in detail, but it's just here to show that we can do rigorous statistical tests to show that there's a difference between the networks. So in summary, I'll let you read the summary bullets as I talk about where to go next. I think network analysis can be a very powerful tool to help us better understand the symptom networks of long COVID. So I kind of ask all of you what questions might need to be answered that could use this sort of methodology and benefit from this sort of analysis. One that has already come up is starting to identify associations between participant characteristics and their symptom clusters. So connections or association between what participants, what it is about them that they end up in one of those symptom clusters, or more likely to end up in one of those symptom clusters. All right, that's it. Thank you.
Thank you